Human immunodeficiency virus, once fatal, is now a chronic condition due to antiretroviral therapy. However, even with optimal treatment, patients face high rates of non-acquired immunodeficiency syndrome comorbidities. This is due to persistent systemic inflammation, reframing human immunodeficiency virus as a chronic inflammatory intestinal disease, with the gut mucosa as the central point of immune activation and organ aging. Of note, the article is not available online anymore, so if somebody wants a copy of the original manuscript, I will post a free access copy. Despite effective antiretroviral therapy, people with human immunodeficiency virus face accelerated aging due to inflammaging, chronic inflammation causing organ damage. Non-acquired immunodeficiency syndrome illnesses like cardiovascular and neurocognitive disorders arise from immune activation. Even elite controllers experience this, suggesting inflammation is partly independent of viral load, highlighting the complex nature of human immunodeficiency virus's impact on aging. Chronic human immunodeficiency virus infection is proposed as a chronic inflammatory intestinal disease, with the gut mucosa as the epicenter. The gastrointestinal barrier drives systemic inflammation, immune activation, and accelerated aging. Disruption leads to microbial translocation, distal organ damage, and persistent immune activation. The gut-associated lymphoid tissue, a primary human immunodeficiency virus target, exacerbates this inflammation through cluster of differentiation 4, positive T-cell depletion. Human immunodeficiency virus target CC chemokine receptor type 5, positive cluster of differentiation, 4 positive T cells in gut-associated lymphoid tissue, causing massive cluster of differentiation 4 positive loss within weeks. Proteomic analysis shows epithelial integrity proteins decrease early. Human immunodeficiency virus type 1's glycoprotein 140 protein disrupts tight junctions, but interleukin 17A-F can reverse this. Plasma biomarkers like intestinal fatty acid binding protein 1 and D-lactate indicate gut permeability, with regenerating islet-derived protein 3 alpha and soluble suppression of tumorigenicity 2 showing early damage. The comparison between human immunodeficiency virus gut pathology and inflammatory bowel disease highlights key insights. Immunodeficiency virus leads to CD4 plus mucosal depletion and immunodeficiency. This is due to the unique combination of viral factors, Th17 depletion, and structural barrier disruption, distinguishing human immunodeficiency viruses' pathogenic mechanisms. Natural hosts of simian immunodeficiency virus, like sooty mangabees and African green monkeys, avoid acquired immunodeficiency syndrome through unique adaptations. They rapidly downregulate CC chemokine receptor type 5 on cluster of differentiation 4, positive T cells, enhance gut repair, and have genetic mutations reducing inflammation. Their macrophages resist simian immunodeficiency virus, and they downregulate interferon responses, preventing immune exhaustion. These strategies offer insights for therapeutic approaches in people living with human immunodeficiency virus. T helper 17 cells decline rapidly after acute human immunodeficiency virus infection, disrupting the T helper 17/regulatory T cell balance crucial for gut barrier repair. Interleukin 17 and interleukin 22, vital for epithelial integrity, are depleted. Regulatory T cells increase, paradoxically serving as human immunodeficiency virus reservoirs. Mucosal-associated invariant T cells, essential for barrier integrity, undergo pyroptosis, correlating with gut damage markers, highlighting persistent mucosal challenges in people living with human immunodeficiency virus. The pathogenic mechanisms of gut mucosal dysfunction form a self-sustaining cycle that antiretroviral therapy cannot break. Tight junction damage leads to microbial translocation, stimulating exhausted immune cells and systemic inflammation. This cycle perpetuates human immunodeficiency virus persistence, highlighting the need to close the leakage to halt microbial translocation and immune activation. In human immunodeficiency virus, immune cells undergo a metabolic shift from oxidative phosphorylation to aerobic glycolysis, akin to the Warburg effect in cancer. This shift, driven by inflammatory signals and human immunodeficiency virus proteins, leads to pro-inflammatory metabolite accumulation and immune activation. The microbiome's composition further influences this metabolic reprogramming, impacting immune function and human immunodeficiency virus persistence. Indoleamine 2, 3-dioxygenase 1, IDO1, plays a crucial role in human immunodeficiency virus pathogenesis by increasing the kynurenine to tryptophan ratio. Promoters of IDO1 activity include lipopolysaccharide-stimulated toll-like receptor 4, human immunodeficiency virus 1, TAT protein, and interferon alpha/gamma signaling. Consequences include increased proviral deoxyribonucleic acid, poor cluster of differentiation 4 plus reconstitution, and reduced cognitive performance. Aging shifts serotonin pathways, enhancing IDO1 activity. In people living with human immunodeficiency virus, PLWH, even on effective antiretroviral therapy, the gut microbiome undergoes significant dysbiosis. Beneficial bacteria like Firmicutes and Bifidobacterium. These changes correlate with immune activation and metabolic shifts, impacting neurocognition and gut health. Short-chain fatty acids like butyrate, propionate, acetate, and valeric acid are crucial for gut health. They support colonocytes, reinforce the mucus layer, and modulate immune responses. Notably, butyrate's inhibition of histone deacetylase offers potential in human immunodeficiency virus cure strategies by reversing latency and promoting viral eradication, linking gut health to systemic anti-inflammatory effects. Proteobacteria overgrowth in human immunodeficiency. Virus dysbiosis increases indoles, activating the aryl hydrocarbon receptor, AHR. While AHR can reduce inflammation via interleukin-22, its overactivation stimulates indoleamine 2, 3-dioxygenase 1, increasing kynurenine/tryptophan ratio. This promotes regulatory T cell formation, inhibits T helper 17 cells, and exacerbates gut damage, perpetuating human immunodeficiency virus persistence in sanctuary sites. Human immunodeficiency, virus-associated neurocognitive disorders, HAND, encompass a range of neurological dysfunctions in people living with human immunodeficiency virus, including asymptomatic neurocognitive impairment, mild neurocognitive disorder, and human immunodeficiency virus-associated dementia. The gut-brain axis plays a crucial role where microbial translocation and human immunodeficiency virus 1 TAT protein activate microglial inflammasomes, causing neuroinflammation and damage. Dysregulated tryptophan metabolism and neurodegeneration mechanisms further contribute to cognitive decline. The multi-compartmental model of human immunodeficiency virus inflammaging highlights the gut mucosal barrier's central role. Dysbiosis depletes short-chain fatty acids, weakening tight junctions. Microbial translocation activates indoleamine 2, 3-dioxygenase 1, depleting T helper 17 cells, impairing barrier repair. The Warburg switch generates pro-inflammatory cytokines, amplifying pathways. Antiretroviral therapy suppresses plasma viral replication, but doesn't penetrate gut-associated lymphoid tissue, leaving pathways active. Future research strategies aim for a functional cure by restoring gut mucosal integrity. Key areas include epithelial barrier repair through Th17-mediated strategies, microbiome restoration to increase short-chain fatty acid production, targeting immunometabolic pathways, and intervening in the gut-brain axis to reduce inflammation and HIV-associated neurocognitive disorder incidence. Chronic human immunodeficiency virus should be viewed as a chronic inflammatory intestinal disease. Antiretroviral therapy alone is insufficient. Addressing gut mucosal dysfunction is crucial. A functional cure requires interventions beyond viral suppression, focusing on gut integrity. Insights from natural simian immunodeficiency virus hosts offer a blueprint for future human immunodeficiency virus therapeutics.